session we are here. I welcome everybody. We stand a pivotal moment in India where the government of India has, in the history of health, has taken up a mission to undertake, ensure that India goes tuberculosis free by 2030. However, Uttarakhand, being one of the Himalayan states, we see that Uttarakhand should be one of the leaders and take an initiative in this. Considering the analytical, if we see India contributes to 27 to 28% of global TB burden, which amounts to more than 1 million cases of TB cases over the world. Though we have achieved, like since 2015, the number of cases have reduced, approximately 21% of the cases have reduced till 2024. But still, we add on to 1/3 of the total cases all over India, all over the world. So, Uttarakhand, we face a lot of challenges. The main challenges are access, because the terrain is difficult. Patients find it difficult to reach to the hospitals. Many of the cases, if they are into drugs, they fail to take the drugs and they develop into multi-drug resistant tuberculosis. One of the factors is also migration dynamics, which we had already discussed earlier. And now, not to talk about the co-morbidity factor, like hypertension and diabetes has been creeping into the Himalayan population. So, the basic pillars could be, what we foresee is to prevent the disease, to promote awareness, provide medicines. Like amongst TB patients, we did a lot of good work. Dr. Pankaj was taking care of the TB program in Uttarakhand earlier. So we had a lot of contribution as Nikshay Mitras, and we supplied nutrition to all TB patients. Apart from this, we need to have a collaborative approach. Today, everybody was talking about public-private partnership. It is not only public-private partnership, it is integration from the government department also. If we have a public-private partnership and expect that the private partner will take the sole responsibility of undertaking all the scope of work which we publish into we provide them with. But it is, unless and until we integrate the whole system, it is very difficult. Considering these factors, a strategy is essential, where we need to undertake NAT testing of all the TB patients, identify the latent cases in the community, provide nutrition, as well as AI-driven tools we need to identify. Like recently we introduced cuff mechanism, where through cuff, we were trying to identify the cases, and it did help us. When we talk about stigma, there is still stigma is existing in the community. And to take on from here, we envisaged that we'll reach out to the population in the villages, and I and Pankaj, we designed a project, and these were the mobile vans, the TB mobile vans, where we were doing the NAT testing and X-ray, along with that, using the AI tool. So it was a real successful model which we developed. I would request Pankaj to just show the process and how we achieved our targets and what we could do through using the TB mobile testing vans. Dear Pankaj.
Thank you, Dr. Tuhin. Am I audible till last year? Thank you. So, thank you for this background. Actually, when I'm going to start with a project, so whenever we speak about elimination of a disease, it is not less than raising a war against a dreaded pathogen. So, Sustainable Development Goal says that we have to eliminate TB by 2030. So, what is the definition of elimination of TB? So, reducing the incidence of TB by 90%, mortality by 80%, and catastrophic cost to everyone's pocket should be zero. So this is a big challenge, and country is dealing with these issues. So टीबी पर स्टार्ट करने से पहले मैं आपको बताऊं प्रॉब्लम स्टेटमेंट क्या है. प्रॉब्लम स्टेटमेंट ये है कि पूरे ग्लोब का 1/4 से ज़्यादा टीबी बर्डन इंडिया में है, और इंडिया जैसे कंट्री को अगर टीबी को एलिमिनेट करना है तो वी हैव टू रेज वॉर एट एवरी फ्रंट. So I am just showcasing one intervention which we developed with the help of public-private partnership intervention and some technologies, like where Vadvani group has helped us in using those technologies through SCUF AI and vulnerability TB mapping. So next slide. So background is TB disease is still associated with huge stigma. We know that कि किसी को TB है तो वो सामने नहीं आना चाहता है, और ये वो लोग हैं जो डायग्नोसिस करने के लिए नहीं आते, और उनकी वजह से ये जो है सोसाइटी में हिडन रहता है, एंड कंटिन्यूड ट्रांसमिशन सोसाइटी में चलता रहता है. So these hidden cases actually lead to continued silent transmission in the community, which goes unnoticed and remains a potential threat to the envisaged goal of TB elimination. अभी 2020 to 21 में गवर्नमेंट ऑफ इंडिया ने फर्स्ट ऑफ अ काइंड नेशनल टीबी प्रिवेलेंस सर्वे किया. उस सर्वे का जो सबसे इम्पॉर्टेंट फाइंडिंग था वो ये था कि 64% ऑफ सिम्टोमेटिक पीपल जिनको सिम्टम्स हैं वो लोग हेल्थ केयर सिस्टम के पास ही नहीं आते हैं अपना डायग्नोसिस और ट्रीटमेंट के लिए. सो बेस्ड ऑन दैट इट इज़ वेरी इंपॉर्टेंट दैट वी शुड एनविसाज सम इंटरवेंशंस एंड टूल्स दैट वी गो टू देम अप टू देयर डोर्स. वी शुड गिव देम एक्सेसिबिलिटी फॉर डायग्नोसिस एंड ट्रीटमेंट. नेक्स्ट. अच्छा, नेक्स्ट. सो दिस इज़ द अनियन पील मॉडल ऑफ टीबी एपिडेमियोलॉजी. आई थिंक काफ़ी लोग जानते होंगे. इसमें जो आउटर की 2 लेयर हैं ये वो पेशेंट्स हैं, द पेशेंट्स विद नो एक्सेस टू हेल्थ केयर फैसिलिटीज़ हु आर लिविंग इन फार फ्लंग एरियाज, डिस्टेंट एरियाज, जहाँ तक अभी हेल्थ केयर फैसिलिटीज़ का एक्सेस ही नहीं है. एंड लेयर 2 इज़ patients with access to health services but do not go to health facilities because stigma and some social reasons. So the project was designed to reach this, mainly focus on these 2 communities. Next slide. So these are recently published some papers. I am also one of the co-author in these. So actually the group is all eminent TB personalities working all over the country. So we just analyze some few research questions like what is the effectiveness and utility of active TB case findings. So both the papers has the observation and recommendation that if you want to eliminate TB, then you have to bring your diagnostic facilities up to the public doorsteps. Otherwise, you won't be able to get the patients on time, and they will lead to delays in diagnosis, and which will further lead to a newer problem, that is TB drug resistance, and their patients are converting into multi-drug TB resistance and extreme drug TB resistance, and that is becoming a more challenge, which is actually including the burden to the dialysis and other part. Next slide. So we initiated the project with simple core 4 objectives. First one is to strengthen early TB detection and expand access to advanced diagnostic services. Second one, our state was that time facing was actually our presumptive TB examination rate was little bit less in comparison to national average and in comparison to other states. So we kept a target of adding the PTER by 300 per lakh population. Third objective was to focus on vulnerable and high-risk population where we will get the clustering of cases. And fourth one, which is most important, is raising community awareness and engagement about the symptoms and seeking health care. Next slide. So this is the pictures of the TB mobile van unit which are going into the fields. So it is a state-specific innovation. ये उत्तराखंड गवर्नमेंट का अपना innovation था, और ये अभी तक और किसी स्टेट में इस तरीके का innovation नहीं है. इसमें previous slide. So नीचे वाला जो बॉक्स है, it says we are working on 4 key principles of primary health care. That is to increase accessibility, acceptability, affordability, and availability of TB diagnostic services in, to the community. Next slide. So these are just the pictures. So 8 TB mobile vans were deployed in the state. Next slide. So actually, the project was done with the proper tendering process with Apollo Hospitals were the service provider. It was a 1-year project. We ran it. It was a technology-driven screening, real time. So we also incorporated ultra-portable handheld X-ray machines. So these are actually ultra-portable, very portable handheld X-ray machine which can be taken to the fields. And the screening of TB can be done at the doorsteps. Next slide. So we chose 5 districts where major clustering of the cases were there. So from our TB data, we saw that around 60 to 70% TB cases were reported from these 5 districts where major urban area is located. So we designed the project for these areas initially. So if we see the program impact at a glance, so in 1-year period, TB risk assessment was done for 78,045 cases. And 37,000 samples were tested, out of which 430 TB cases were diagnosed. So apparently ऐसा लगता है कि number of cases कम है, but actually these are the cases जो health system तक नहीं आते हैं, और ये वो cases हैं जो आगे 10 से 15 लोगों को भी TB transmission कर सकते हैं. That is the normal epidemiology of TB disease. So we are not saying about 430 cases, but we are saying about 430 multiplied by 10 to 15 cases in the field. Next slide. So these are the number of camps जो पूरे साल में in vans ने किया. Next slide. So this is how we monitored our efficiency and effectiveness. So we can see from January how we raised the number of individuals tested for TB and the number of positive cases detected. That is in the increasing trend. Next slide. And this is the MMU-wise performance, how they were performing. So this was actually for monitoring and improving the course of action of these vans. Next slide. So this graph is showing how yearly we have raised our presumptive TB examination rate. So in 4 years, from 914 per lakh population to 1869 per lakh population. Next slide. So there are some glimpses from the field. Next. So a small intervention I would like to reiterate here. So that is Vadhwani AI Cup. So Vadhwani group approached us, and that is actually Government of India adopted intervention. So they came with 2 interventions. That one is, next slide. Next slide. So this is the problem statement basically I have already told. Next slide. So there were two interventions. First one is CAFI, where the mobile has a mobile app, and that app records the sound of a patient. And the particular sound of a patient is basically used as a tool for screening the probableness of TB disease. So if anyone coming positive through that AI model, through their coughing sound, that person goes for NAT testing, that is molecular testing. Another is vulnerability mapping. So some areas were identified through the TB data and other factors, that which areas were more vulnerable for TB, where the TB clustering is there. So these 2 digital electronic tools were actually utilized by us. Next slide. So this is how we did the training of all the staff in all over the district. Next slide. So these are the pictures of some on-site trainings. Next slide. So this is the last slide. Actually, we didn't got that much time to showcase our work, but we can see here that with adding cuff AI and vulnerability TB mapping, we can see that our positivity rate increased from 1.6% to 2%. So I hope, and I actually, I say if we use more digital technologies, AI, vulnerability mapping and other, then we can definitely win this war and we can end TB. Thank you.